Good evening. Welcome, everyone. I'm Shireen, one of the founders of the Lyme Care Resource Center. Bill Kenny and I established this organization to support those navigating the journey with Lyme disease, either in themselves or in a support role. We like to remind our community that there is an interdependence of mind, body, and spirit in promoting healing. Also, our community helps to remind us that we are not alone in this journey. We're glad you've joined us tonight. Many are familiar with, or at least have heard of, Maslow's hierarchy of needs. In his paradigm, basic physiologic needs form the foundation of a pyramid, and the needs become more complex as one ascends from the space. The theory is that as the needs of each level are met, one can then move up to the next level, and so on. While these levels build upon one another, they are all connected rather than siloed. And it is not the case that the hierarchy always follows a linear path. We can certainly feel various needs at the same time. But it is the case that if needs at a lower level are not met, it can become more difficult to achieve the more complex ones. If we take this concept and apply it to living with Lyme disease, we can see that human needs are affected on multiple levels. First, there's the basic needs of food, water, sleep, and health. And when we're struggling at the base of the pyramid with physical symptoms, it can be very difficult to address the subsequent levels of safety, belonging, esteem, and actualization. When we reach out to a practitioner for help with our basic physiologic needs, we are in essence reaching for the next level in the hierarchy, a sense of safety. If at that level we are unheard and perhaps dismissed, well, now we're challenged on that level as well. And as we have experienced, the invalidation of our needs during the search for safety, of course, can make the more basic physiologic needs feel even more severe. Furthermore, safety and security are challenged by a lack of predictability. And as we know, one of the predictable hallmarks of Lyme symptoms is that they can be unpredictable. Moving up to the third level, belonging and being part of a community. This can be a comforting realm, but this level can also struggle as we become isolated by an inability to fully engage due to our necessary preoccupation with the more basic levels of physiology and safety. Then there are the fourth and fifth levels. The fourth is esteem, a sense of confidence, and fifth is self-actualization, reaching one's potential. The needs and motivations of these layers also struggle when the path forward toward resolution becomes unclear. This brief overview of Lyme as lived through Maslow's hierarchy reminds us that when the foundation shakes, everything that rests upon it shakes as well. The purpose of seeing these challenges in this way is not to overwhelm us with a lack of hope, even though hope is what's shaken at each level. The purpose is rather to empower us with a sense of grace for what we go through. Because only in allowing ourselves to recognize the true impact of our experience can we befriend ourselves at each level and become our own best healer. Tonight's topic, invalidation, strikes us at the level of safety and security. As people search to have these needs met, one thing becomes clear. One cannot comfortably trust their cause to those who would dismiss their reality. So we keep searching and we keep striving, and as hard as it may get, we do not surrender ourselves to those who would do further harm to our fundamental needs by either omission or commission. We do not allow the invalidation we experience from others to cause invalidation of ourselves. Rather, we can seek to have our needs addressed by those in the ever-growing group of practitioners who understand that their patients are multifaceted human beings. These practitioners are better able to recognize that those who seek their care may be struggling not just on a physiologic level, but also on levels such as safety and belonging. In applying that truth to their practice, they address these needs, or at least recognize them, and take care to do no harm to the already fragile physiologic foundation on which they rest. Tonight, we're once again blessed to have an expert in the Lyme world as our guest speaker. Alison Rebman is here to share her research, the scientific studies, the insights, and the implications of an incredibly important topic that affects so many in the Lyme community. Alison first spoke to our community shortly after the center was established, and at the time, she spoke about the patient experience and how so many live in limbo with this illness. Since then, Alison has conducted many studies and authored many papers, all of which have moved us forward in our understanding of the qualitative aspects of living with Lyme. From the earliest days of John Aucott's studies, Alison has contributed in myriad ways, from setup to follow-through, from concept to conclusion. We are grateful for her many contributions and for her presence here tonight. I now pass the screen to our director, Gina, for her welcome.
Hi, everyone. I'm Gina Costa, and I wanted to welcome everyone and thank Shireen for your amazing introduction. I think you really hit the nail on the head, and it's really important to think about ourselves, how we feel about ourselves, how we respond to our situations. And when I was sitting and thinking about what I wanted to say to everyone today in the welcome, I was thinking about the significance and the importance of being seen, heard, and understood. I was thinking about the value of receiving education and awareness and how that guides our decision makings and ultimately guides our thoughts and our behaviors. I was also thinking about something so near and dear to my heart is just the meaningfulness of connection and support. And when I was listening to everything that you shared, Shireen, I was thinking about the power of connection and what that means to our community. And so much is in our experiences. We all have unique stories. And I think that the science and the research and the stories and the testimonies all together are extremely empowering. We can't wait to hear the talk tonight. And the power of connection, it really refers to the importance of building strong relationships within ourselves and others. And I think, everyone that has been directly impacted by Lyme, and even loving and caring, supportive families and family members and friends that are supporting us, it can be really difficult to really focus on the relationship with ourselves because so much is changing, especially people that have chronic challenges. And I think just when we really try to focus on being our strongest and best advocate, it's really important to take a look at what our needs are. And that hierarchy is really relevant. So thank you for sharing that and just explaining it in such a beautiful way. And I think that, when we really focus on doing something positive for ourselves and building our education, because it really does guide our outcomes, and when we focus on connecting with other people and trying to surround ourselves with people that lift us and motivate us and inspire us, it's a beautiful thing, and it can help us improve our well-being. It can help us improve our self-esteem and our sense of purpose. And all of these are so deeply important for our quality of life. I just want to thank everyone that signed on. I know we have patients on this call. We have family members, people in support roles. We have some doctors and practitioners. And I think that the opportunity to sit and listen to the latest research tonight is of great value. And it's very important to always be seen, heard, and understood, and to really take a deep look within and think about who we are, where we are, and really how we want to build our relationships with ourselves and how we want to build it with other people as well. So tonight I wanted to take a moment just to tell you about our format. And we are extremely blessed to have two people from the Johns Hopkins Medicine Lyme Disease Research Center. So Alison has prepared a talk, and we have so much gratitude for her time and expertise that she's going to share with us tonight. We also have Miss Nancy Doherty joining us, and Nancy spearheads the Research Center's communication and education outreach efforts. She is a special advocate for our community. Nancy's a woman of many talents, generosity. She's compassionate, and she's been an incredible support to our nonprofit over the years. So Nancy is going to be the moderator for question and answer. So you'll notice on your screens the Q&A feature. And at any point throughout the night, if you have comments or questions that you'd like to share, if time allows, Allison's going to address some of those or all of those. At this point, I wanted to welcome Miss Alison Rebman. We're welcoming her back. And Alison has a master's in public health. She earned her graduate degree from Columbia University in Sociomedical Sciences. Alison is an assistant professor in the Division of Rheumatology within the Department of Medicine at Johns Hopkins University. She's also the director for Clinical and Epidemiological Research at the Johns Hopkins Lyme Disease Research Center. Alison began working in the Lyme disease field in 2008. She has co-authored over 50 peer-reviewed publications and book chapters across a variety of disciplines within the Lyme disease field. I want to thank you, Alison, from the bottom of our hearts for taking the time to prepare this presentation. And I want you to know how much it means to us and our friends that are also on this call. We want you to know that your time is valued, your expertise is influential, your research is meaningful, and your passion to help and give back to us out of the generosity of your heart provides a comfort and a special hope. So at this point, I just wanted to thank you on behalf of our Lyme Care Resource Center nonprofit, and I wanted to turn it over to you. Thank you so much.
Wow, thank you, Gina. That's a wonderful introduction. Thank you, Shireen. That's so meaningful to hear. I'm going to go ahead and share my slides. Let's see. I think that's good. 1 second. Apologies, 1 second here. Okay. All right, I think I'm good. Yeah, so thank you again, Gina and Shireen and Phil and everyone at the Lyme Care Resource Center. I'm always especially and very honored to be invited to speak to this group specifically. And as was mentioned, I've done this once before. I was just looking back, it was 8 years ago. So it's really nice to first of all, be invited back, and secondly, to have some more thoughts and research and ideas to share about this topic. So tonight, I'll be talking about invalidation, gender, and the medical encounter in Lyme disease, which is a big topic. It encompasses a lot of different disciplines. And I want to start off by saying and acknowledging that I know that there's a lot of lived experience around this topic for people on the call, whether you have a history of Lyme disease or not. And so kind of with those things in mind, I want to try and be concise because it is such a big topic. But secondly, I want to really try and focus on the science behind these issues. And why I think they're really important, and why I think they're overlooked, specifically by physicians, but also I think by patients as well. So for tonight's talk, I'll start just by kind of going over doctor-patient interactions in Lyme disease, talk about specifically illness and validation in the context of Lyme, and then in other conditions as well, and talk through some recent studies, including one that our group just published earlier this year. And then talk a little bit about the influence of gender, past and present, on some of these issues, and then think through some future directions and what I think of as kind of take-homes or ways forward for this work specifically. A couple of disclaimers: I'm not a physician, I'm not a psychologist, so I can't and won't really be talking about treatment specifically. But my hope for this talk is that I do hope that it offers potentially some new ways of thinking about these experiences, and maybe offers a sense of not being alone in them, which I know, as Shireen and Gina articulated beautifully, is one of the key missions of the Lyme Care Resource Center, which is wonderful. Okay, so to start, a few words on language and terminology. When I talk about Lyme disease in the context of this work and in these studies, I'm really talking about persistent symptoms after initial treatment, which we know may or may not also include co-infections. So I'm really talking about what we think of as chronic Lyme disease, right? So after treatment and these long-term persistent symptoms, I'm not we're not looking at acute Lyme, EM rash, or presentations prior to treatment. And we know that these persistent symptoms, the naming of them have really shifted over time. I think they were first kind of mentioned in the literature in the 80s. Alan Steer called them minor late symptoms. The name has really shifted around many times over the years, as you can see. With the advent of COVID, the term long haul Lyme appeared. And more recently, I think in the past year with the National Academy's working group, the term Lyme infection associated chronic illness was adopted and has been used more recently in the field. And so in terms of kind of a current conceptualization of some of these terms, if you hear me use the term post-treatment Lyme disease, PTLD, that's really patients that meet a very specific research case definition with pretty high specificity. And so we know that that represents a subset of patients that are part of that broader picture of patients with chronic Lyme disease, or LIACI, Lyme infection-associated chronic illness, which is a broader definition that's more clinically based. And I think especially in recent years, especially following COVID, there's this bigger understanding that all of this is part of a broader picture of these general infection-associated chronic illnesses, like fibromyalgia, like ME/CFS, chronic fatigue syndrome, and certainly that symptoms can persist, and these syndromes can occur after treatment or after initial infection of COVID-19, Epstein-Barr virus, West Nile, Q fever, dengue, and the list goes on and on. So it's really part of kind of this bigger picture. If you have seen Dr. Aucott from our center talk before to this group, or otherwise, you've likely seen this slide. There are many potential mechanisms that have been proposed for Lyme disease-associated chronic illnesses. And certainly there's research ongoing in all of these domains at our center and elsewhere. If the first is kind of inflammatory processes due to dysregulated immune response, autoimmune responses, metabolism alterations, et cetera. The second is more microbial mechanisms, so persistence of Borrelia or pieces of the spirochetes, other tick-borne or coexisting infections and microbiome alterations. And the third is sort of these neural network alterations, the apparent neuroimmune interactions. And these certainly can coexist or can interface with each other. But on top of those, there's other factors that kind of contribute to how we think about and how we research these Lyme-associated chronic illness. The first is host genetic environmental factors, genetic variability, things like patient sex, age, or race, environmental exposures that kind of overlay onto there, other microbial factors. And then the last piece that when we kind of conceptualize how we do research in this field lives in kind of this bottom left quadrant, and that is illness experience factors, diagnosis and treatment delays, this kind of world of psychosocial stressors, potential trauma, illness invalidation, coping, all of these things. And so I think tonight's talk really lives in this lower left quadrant down here. And so what I'm going to try to do tonight is to make the case that this is an important piece. It's an important overlay onto these other factors. It's obviously not the whole picture. All of these things are ongoing in Lyme infection and then following, treatment and persistent symptoms, all of that. But that this is an important consideration and should be studied and thought of as well. Okay, so Turning to the doctor-patient relationship and interactions in Lyme disease, back in 2015, the last time I spoke to this group, we had done this study, Living in Limbo. And what we did is we conducted interviews with patients about kind of their narratives on living with chronic symptoms following Lyme disease. There really hadn't been much in the literature, and we wanted to take a really broad approach. And I think that what really struck us is how often what doctors had said to patients, how those interactions had gone, how they felt when they left the doctor. That was a huge piece of their narrative, of their illness experience story. And it was so huge that when we went to publish this paper, we said, well, that's its own paper, that's its own research. And we kind of put it off to the side, published this paper and said, well, we're going to come back to this and study it separately. And so we did. But I think, you know, when you talk to patients about having a broken leg or something, you don't quite get the depth of these stories around how they interacted with the medical system and what went wrong. And so there's something kind of unique to these stories, and that's what I want to talk about tonight. I was thinking about this, and these are things that patients have said to me just in the past month in the context of doing additional interviewing in this area. So my doctor's saying it's all in your mind or it's not really there. I can't really blame the doctors. They don't know about it. If you don't know, just tell me that. I can handle the truth and just listen to my story. So, you know, I'm confident that I could ask on this call and that patients who have a history of Lyme disease would repeat some of these similar kind of anecdotes and stories. I think there's kind of a universal experience here. And so what we took away from this is that the interactions with physicians are really a key piece of the story, and that obviously they're not always positive. It's kind of an understatement. So if we first go to the scientific literature to see what's been published, to see, you know, what we can learn from there, there have been several studies that have kind of described doctor-patient interactions in Lyme disease, particularly in qualitative research. That means, you know, research where it's more interview-based to try and understand what's going on. One of my favorites is now almost 25 years old, from the sociology literature. Mechanic and Meyer compared patients with chronic Lyme disease, patients with breast cancer, and patients with serious mental illness on their stories in terms of their trust in physicians. And what they found in terms of the chronic Lyme patients is that rejection by a physician was mentioned almost exclusively by the chronic Lyme patients, not by patients with breast cancer or with serious mental illness. And that chronic Lyme patients were twice as likely to report a loss of trust in physicians as were patients in the other groups. So while there have been studies to describe this phenomenon, there really have not been any to kind of try and quantify it and to understand further the nature of the impact on Lyme patients. That really doesn't exist very much in the literature. And there was a recent review article from just a couple of years ago that concluded that really there have been no studies in Lyme disease that have specifically addressed patient-provider interactions and relationships as their primary objective of the study. So there really is kind of a hole, I think, in the scientific literature here, especially given how important it seems to be to patients and how important it seems to be to their stories. Okay, so if we kind of take as our background that patients with Lyme often report negative interactions with healthcare providers, then you can start to ask more kind of deeper research questions around this. Like, why is it happening? What is unique to the Lyme disease setting that's causing this to happen? What specifically characterizes these interactions? In other words, are there specific words or phrases, or where in the interaction do things turn positively or negatively? And more importantly, what is the effect on patients? And then how can we think about improving patient experience and then also physician practice? And so this kind of drove the research that we did. And shaping all of this kind of in the background, if you like the social sciences like I do, is the fact that Lyme disease exists within a specific social environment. And that social environment trickles down to, one patient sitting in front of one physician, and it informs those relationships. And so, as we know, there's no FDA-approved treatment for chronic Lyme disease. There's arguments and controversies, there's contentiousness that exists in the public space and certainly historically has, and that this represents a really unique, what we call contested patient experience. And so I use the word contested. This is a concept from the sociology literature that's been around for some time. Contested illnesses are a specific category of illnesses whose real existence is questioned or disputed by members of the medical field. And they have a really particular cultural meaning. They're characterized by, specifically by discord between sufferers who have an often medically invisible condition, and then modern high-tech biomedicine that wants to identify biomarkers or wants to find objectively things wrong. And so they're really characterized by this kind of contested discord. My favorite quote about contested illnesses specifically are that they are ones that you have to fight to get. And I think that's really telling about the patient illness experience here. And so this category of conditions, often in the literature includes things like fibromyalgia, ME/CFS, chronic fatigue syndrome, Gulf War illness, and now I think long COVID as well. And there have been a few papers, ours included, that have argued that Lyme should be considered a contested illness as well. Okay, so with that, all of that kind of background in mind, we then conducted a study more recently that was published earlier this year in this area, Invalidation by Medical Professionals in Post-Treatment Lyme Disease. We focused on invalidation specifically as an aspect of the doctor-patient relationship because there's a little bit of literature on invalidation in other conditions and other contested illness conditions that we could draw on to kind of inform this work. And also because in our previous interviews and our previous qualitative work, invalidation really seemed to be a flavor of those interactions. And so we wanted to kind of go after that. It seemed like patients were really indicating that that was an important piece of their interactions. And so I think this was perhaps the first quantitative study to look at these issues in Lyme disease. And so I want to kind of present the background and the findings on that work. So invalidation itself as a concept is the process through which the legitimacy of another's experience, can be their emotions, thoughts, or behaviors, etc., is called into question. It is by nature a psychosocial phenomenon in the sense that it exists in interactions between people. It exists in these interactions. There are several different forms of invalidation. There's differing levels of severity. If you've seen the term gaslighting in the media, that seems to be a popular term. My understanding is that that's more a specific form of control. It's a more severe form of invalidation, and it's a more intentional form that involves manipulation. And invalidation itself, I believe, was first kind of described in psychology by Dr. Marcia Lyman, who was a psychologist interested in invalidation in childhood and the effect on later mental health. And so if we kind of take that concept of invalidation and drill down a little bit specifically to illness invalidation, that can be defined as the patient's perception that their medical condition specifically is not recognized by the social environment. And the social environment can be spouses, family, medical professionals, the work environment, social services, et cetera, et cetera. It kind of made its way into the scientific literature a bit more recently, at least in the illness invalidation piece of it. Marianne Kool, who is a Dutch researcher, has done a lot of work in fibromyalgia and rheumatoid arthritis, and she developed something called the Illness Invalidation Inventory, the 3I, which is a measure that can be used, a questionnaire that can be used to measure kind of the degree of invalidating experiences. And this measure and the way that she conceptualizes illness invalidation has two dimensions. The first is lack of understanding. So that's kind of not actively receiving more positive things like recognition, comprehension, or support. And then discounting, which is thought of as a more severe form of invalidation. And that's really kind of actively negative expressions of disbelief, admonishing, dismissing, or rejecting. So lack of understanding is thought to be kind of not receiving some of those positive attributes, and discounting is more actively negative. Now, there are many ways that invalidation can show up in the medical encounter, in a doctor's visits. These are a few examples. I'm sure that, again, people on this call could add to this list. Minimizing symptoms, like feeling like you're being told it's all in your head, feeling like a burden, or feeling like you're overreacting. The immediate attribution to a specific demographic factor like age or gender, saying, oh, well, you're tired or achy because you're just getting older. Immediately assigning a mental health diagnosis, or dismissing concerns as minor. And so with that in mind, we wanted to do a study, and we wanted to ask the following questions. The first is, how much invalidation on this measure, this 3I illness invalidation inventory, are patients actually reporting? And is there a relationship to symptom reporting, to severity of PTLD? So do patients who report more invalidation, do they report more symptoms? Are they having a harder time with their Lyme disease? And secondly, who is at increased risk for reporting more invalidating experiences? Are there factors that we can tease out, like risk factors, demographic or clinical, that can help us identify who is at most risk for reporting more of these types of experiences? And we decided to focus only on invalidation from healthcare providers as a starting point, because we were interested in that as a topic. And we also wanted to make sure and keep a specific focus on the potential effect of gender, because that was another theme that came out in our interviews, and because there is some research in this area as well. So we ended up enrolling 80 patients who met, again, our research case definition for post-treatment Lyme disease, who were seen at the Hopkins Lyme Center. They all completed the 3I, the illness invalidation inventory that I mentioned. They completed the SF-36, which is a commonly used measure of quality of life. They completed the PLQS, which is a post-Lyme questionnaire of symptoms. It's a symptom survey that measures presence and severity of symptoms in Lyme. The Trust in Physicians scale, which is another independently created scale measuring trust. And then 4 independent invalidation questions that we developed based on our qualitative work, and we specifically wanted to ask patients about, that we felt were maybe a bit more specific to Lyme disease. And then we were able to take that 3I measure and generate lack of understanding and discounting subscales, so we could measure both of those aspects of invalidation. So here is who ended up in our sample of 80 patients. The average age was a little bit older, a little over 50. It was fairly evenly split between men and women, slight minority women, 45%. A few things to point out. We had very high white non-Hispanic in terms of race and ethnicity, and pretty high levels of income and education in our sample. The average illness duration was just under 5 years for how long people had been ill. And then I wanted to point out too that In terms of patients' initial Lyme clinical presentation, only about 43% had an EEM rash at their onset. We had another 20% who had another objective finding like neurologic disease, cardiac disease, arthritis. But our sample had 40% who had a positive serology and symptoms only. So they didn't have a rash, they didn't have late Lyme arthritis. And we actually hypothesized that those 40% of patients without a rash or other objective findings would have greater levels of invalidation, that they'd be more at risk due to the fact that they didn't have one of these, quote, objective findings at onset before they were treated. And so what we found was that about half of our sample reported pretty significant lack of understanding from healthcare providers, and about a third reported pretty significant discounting from healthcare providers. And so what we concluded here is that as a starting place, invalidation is common. It's not universal, but it's very common in the sample. And compared to other studies that have been done with other populations, to put this in context, patients with post-treatment Lyme disease reported slightly less invalidation than those with ME/CFS, chronic fatigue syndrome, but similar or more invalidation than those with fibromyalgia, and more invalidation than patients with RA. So it's similar to these other contested illnesses where people have done this work previously. When we looked at the other measures that we administered to this sample, we found that people who reported higher levels of invalidation also reported higher levels of symptoms on our questionnaire of symptoms. They reported lower levels of quality of life, especially in the mental health component. This quality of life measure has a mental and a physical health component. And they reported lower overall trust in physicians, which makes sense. That's a fairly obvious conclusion, that if you feel more invalidated by healthcare providers, you're going to probably lose trust in physicians. This is the correlation matrix showing those relationships, which we don't need to walk through all the details, but this is just to show that these relationships are fairly strongly statistically significant. And they're also, in terms of the strength of the correlation, they're pretty significant as well. So these are pretty strong relationships. The second thing to note is that I mentioned those discounting and lack of understanding subscales. These relationships are stronger for the discounting subscale on our 3I measure. So which makes sense as well. So if you've had more of those negative discounting experiences, you have even more of an increase in your symptom burden, decrease in your quality of life, et cetera. So the next kind of question that we had about this was, well, if there's a relationship between invalidation and higher levels of symptoms, which symptoms? You know, is it across the board? Is it mental health? Is it fatigue? What does that look like? And what we actually found, this is kind of a small graph to read, but what it's showing you is on the left is the relationships with the lack of understanding subscale. Those are the green bars on the left. And on the right is the relationship with the discounting subscale. So the blue bars are on the right. And what we found is really that these invalidation subscales are associated with a range of symptoms. It's not just one kind of flavor of symptoms. There's really a lot that it's driving up. And in particular, with the discounting subscales. So if you look at the blue bars, they're more significant, they're stronger relationships. So that's kind of consistent with what we found before. But one thing that we did want to note is these are the strongest relationships are at the top of this graph. So difficulty concentrating was actually the symptom that was the most strongly related, followed by irritability, headache, depression, et cetera, on down. We did find that the mental health symptoms we think are overrepresented. They're near the top of this graph, right? They are symptoms that are not the most commonly reported in our sample population. They're actually only reported by, anxiety is reported by about a third, irritability by about a quarter, and depression by 15%. If you compare that to things like fatigue and pain, which are reported in the high majority of our population, they're not super common, but they are some of the strongest correlations with these measures. So what we took away from this is that, yes, they're a little bit overrepresentative, but they're not the only ones, right? You also see things like headache, muscle pain, neck pain, even fatigue is showing up as well. So invalidation really does kind of drive higher symptom reporting across a range of symptoms. And then the last thing that we looked at was, as I mentioned, risk factors for invalidation. So in other words, are there things that we can identify statistically that shake out as being associated with reporting higher levels of invalidation? So what we did is we performed some regression models looking at the 3I scores, the outcome, and various demographic and clinical variables as predictors. And what shook out is that women and younger patients reported more illness invalidation after controlling for other factors, which is not terribly surprising. It's the trend that is reported kind of across the board in a lot of other conditions as well. But I think what's interesting here is not what we found. I mean, this is interesting, but also what we didn't find. And what we didn't find is that education was not related to invalidation. And then importantly, I think whether or not you have an EM rash at your initial presentation was not related to how much invalidation you reported from healthcare providers later down the road. And being in that initial group that I kind of highlighted as having no objective findings at initial presentation, that was also not significantly related. So we tested those and we found them to be not significant. And so I think what that means to me is that kind of these broader societal patterns of invalidation exist in Lyme disease as well, but then also it kind of doesn't really matter how you present initially. I think once you cross into kind of having these chronic symptoms, you're at risk for invalidation regardless of what your initial presentation was. And I think that's important to know as well. Okay, so I'm gonna switch gears a little bit and talk about healthcare bias, which are the conscious or unconscious beliefs that are held that can lead to care being distributed differentially across people. And there's a whole host of factors that can kind of lead to biases. Gender, race, ethnicity, certainly we know about. That's more in the media, that's more in the literature. But there's also factors that aren't as thought about and not as well studied. Things like socioeconomic status, disability status, cultural differences, body weight, even personality traits. So there's a kind of a whole host of factors that can lead to specific biases. And in our work, as the title of the talk suggests, we sort of tackle gender to begin with. As I mentioned, there's more of a literature here, and this seemed to be a really important topic to go after based on our initial qualitative interviews. Now, this is a little bit of an aside, but as you may know, there's a long history of gender inequities in medicine. Hysteria is kind of this classic example. It was first described by the ancient Egyptians millennia ago. It actually comes from the Greek word hystera, which means uterus, and it was kind of conceived as this exclusively female mental health disorder. And so it became kind of this catch-all for mental illness, but also any behavior that was not deemed socially appropriate. And it also, has taken on kind of a life, or took on a life as a synonym for being overly emotional. We obviously still have the word hysterical with us today in our language. And I think it wasn't really until kind of the mid-1900s when Dr. Elliott Slater sort of famously followed up on a group of patients with the diagnosis of hysteria and found that many of them actually had underlying neurologic disorders. And he kind of famously said the following quotes: "The diagnosis of, quote, hysteria is a disguise for ignorance and a fertile source of clinical error. It is in fact not only a delusion, but a snare." And he kind of concluded that hysteria is a disorder specifically of the doctor-patient relationship. And so mention this because I think it's interesting. The history of medicine is interesting, but also there's a historical legacy here that many would argue is still around in different forms today, showing up differently. But I think that it's important to consider. And if you look at how this is still kind of showing up in modern day examples, these are a couple of papers just from the past few years looking at gender stereotypes around pain, both in medicine and research, but also just in the general population, because these things don't exist in a vacuum. They kind of are part of the general, population as well. And you can see some of the adjectives that are commonly used and pulled out of these review articles, that women exaggerate and men downplay. The second article is entitled Brave Men and Emotional Women. This term emotional keeps coming up. And it's the idea that men are often stoic, that they're better at tolerating pain, they're better at denying it, they're more autonomous, and they're more avoidant of healthcare. Whereas women are more sensitive, they're more willing to report, and they're more used to pain. And there's something kind of inherently natural for women about experiencing pain. And so you can see some of these adjectives that are even still currently kind of, being thought of. And this translates to, the reality is that this really translates to differences in care. In keeping with kind of the pain model, there's a lot of literature on differential estimations of pain severity among men and women and provision of necessary treatment. So in one recent study found that women were 13 to 25% less likely to receive pain meds in the emergency room for acute pain, even when they came in giving the exact same pain scores as men and having similar conditions, and they tended to wait 15 minutes longer to receive them. And so in general, there's this, a lot of literature showing that women historically kind of have received less and less effective pain meds and tend to receive more antidepressants and mental health referrals for things like chronic pain. There's also a host of literature showing that women often have a longer time to diagnosis and are more vulnerable to misdiagnosis in the process. And a lot of this, part of this can come from the fact that women historically have also been underrepresented in medical research. Even just recently, a study from 5 years ago showed that women made up 40% of participants in cancer, heart disease, and psychiatric disorder clinical trials, despite being 51% of the population. And even when women are included in trials, I found a recent article showing that only 5 to 14% of studies across disciplines even examine outcomes by sex. So even when women are included, we don't often analytically consider how these diseases might present differently among men and women. So I think, again, there's kind of this legacy here that women are more dramatic, more emotional, and maybe kind of over-reporting their symptoms. And that leads to real differences in care. And so now I'm switching gears back to our research here, back to our study of 80 patients with post-treatment Lyme disease. These are the 4 questions that we generated that we wanted to ask our patients. We asked whether they had ever felt rejected by a healthcare provider, whether they felt that a healthcare provider had doubted the severity of their illness, whether a healthcare provider had doubted that their illness was real, or whether they were told their illness was only or in large part due to psychological causes. And what the graphs are showing, the men are the blue bars, the women are the orange bars, and it's showing the percentage of patients who endorsed these 4 statements. So you can see for all 4 of them, women are endorsing these to a greater degree. And for 3 out of the 4, this was statistically significantly different. You can also see the orange kind of dotted line is the 50% mark. So you can see that in general in our sample, these statements are being endorsed by a large proportion of our sample. And so the last kind of data point that I want to make from our study relates to being given an alternative diagnosis for symptoms of chronic Lyme disease. And so we asked patients in our study if after they had been treated for Lyme disease and they had these ongoing persistent symptoms, if they had been told that their symptoms were due to something else. And we interestingly found that about 10% of men said yes, but about 40% of women said yes. And so the odds ratio on this was almost 5, and it was statistically significant. And so we thought that this was really interesting, and we wanted to dig a little further into it. And we actually conducted what's called a mediation analysis to see if receiving an alternative diagnosis could be a mediator in the relationship between gender and invalidation score. And so what this means is that we know that women report higher levels of invalidation than men. And we wanted to see if this specific factor, if being told that your symptoms were due to something else, could explain some of that difference in reporting between men and women. And statistically, it did shake out, and it does serve as a mediator in that relationship. It doesn't explain everything, but it does seem to play a role. And so we concluded that one potential basis for higher invalidation among women is the more frequent attribution of their symptoms to other conditions by a healthcare provider. Which leads to kind of a couple of follow-up questions. The first that we had was, well, if we're seeing this difference in being given an alternative diagnosis for the chronic symptoms, does it exist pre-treatment as well? Does it exist during the acute phase when patients are presenting initially before treatment? And interestingly, that difference actually was not there during acute disease. So it's only really after treatment, once kind of the chronic symptoms have developed, that we see this difference. And secondly, if patients are being told their symptoms are due to other conditions, well, which ones? Which other conditions are they being diagnosed with? And so we did take a look at that. There were 19 patients who received an alternative diagnosis for their symptoms of post-treatment Lyme disease, 14 women and 5 men. Again, it's more common among women. And what we found is that 57% of these women were told that they actually had another contested illness, so fibromyalgia, irritable bowel syndrome, ME/CFS, et cetera, and only 20% of men were told that. Similarly, a higher proportion of women were told that their symptoms were due to a psychological illness like depression or anxiety or post-traumatic stress, compared to 29% of women compared to 20% of men. And if we look at the flip side, on if they were told only that they had an uncontested diagnosis, so not a psychological illness, not another contested illness, and only 29% of women were given an uncontested diagnosis, but 60% of men were. Now, this sample size is really small. The p-values on these were actually not significant, so we can't really conclude that there's a difference. However, I think it does represent a trend, and it's in the direction that we kind of would expect here. Okay, so before we move on from our actual research, from the study results, I do want to just mention a few limitations of our study that maybe you thought of. The first is sample generalizability. So generalizability is the idea in research of how representative your sample is that you're studying to the general target population of patients that you want to be able to speak to. So in our case, as I mentioned, we had really high education, high income, and kind of lower racial and ethnic diversity. And so that's kind of a concern and something to think about for future studies to address. Secondly, we want to think about if our population of patients who met criteria for PTLD can be generalized to the broader population of those with chronic Lyme disease, that Venn diagram that I showed at the beginning, and whether that's really generalizable. My guess is that it may not be, and that we may need samples of broader population samples of patients with chronic Lyme disease to really understand what's going on. There certainly may be a response bias in who responded to our recruitment. It could be that people who had really positive or really negative interactions with providers wanted to participate in the study in order to share their experience. And then lastly, there may be bias in who received care at our center, who had the resources or the knowledge base to kind of seek care and be seen at our center. And then another thing to think about with our findings, this study was a cross-sectional design, which means we only studied people at one specific time point. And so we couldn't address the directionality of our results. Directionality meaning kind of what leads to what. And that's impossible or very hard to do with studying people at one time point. We certainly found a relationship between higher levels of invalidation by healthcare providers and greater symptoms, decreased quality of life, and decreased trust in physicians. And it certainly makes sense to kind of hypothesize that it goes in that direction, that the more invalidation you've experienced, the more your symptoms, the lower your quality of life, et cetera. But it's also entirely possible that the arrow goes the other way or that it goes both directions. You could also hypothesize that patients who have more symptoms due to genetic susceptibility or different Borrelial strains or co-infections or any of these number of factors could then be at increased risk for invalidation as a result of their clinical presentation or some other factor. So I think we have to be a little bit careful in understanding the direction of these relationships. And the same could certainly be true for the mental health symptoms specifically. You could think about these going in either direction. But that said, I think as kind of a first quantitative smaller study to look at these issues in Lyme disease, we found the findings interesting. Our conclusion that we really interpreted and wrote in the discussion was that illness invalidation by healthcare providers may exacerbate illness burden and complicate healing trajectories, particularly for women and for younger patients. And so in thinking about our findings, what they mean, how they might be relevant, and how they might be translatable, I think that what I took away is this may be a more deeply impactful experience than is generally appreciated. And so to sort of conclude that, we need to look at evidence from other studies or other conditions to see what we can learn and see if that might be true. And so I want to walk through some of that as well. Because as I mentioned, invalidation hasn't been studied in the Lyme disease context in this way. So we kind of have to borrow pieces from other disciplines and other conditions. So illness invalidation has been certainly linked to mental health concerns. Among patients with fibromyalgia, it's strongly related to levels of self-reported loneliness. It's also another study found in college students, some of whom had chronic pain, that those with pain who experienced more invalidation had higher levels of depression. And interestingly, I think the reason why I highlighted this study is that they found that relationship was actually mediated by a sense of shame. And so shame may be this mechanism through which invalidation is internalized into something like depression or anxiety. We also know from other studies that adverse social interactions, of which invalidation is one, can certainly affect immune processes in kind of the cancer research, in other kind of immunologic-based research. These adverse social interactions can increase inflammation, can dampen the antiviral responses in people. And then lastly, there's kind of this interesting hypothesis around the nocebo response, which was new to me in actually reviewing some literature for this talk. You've probably heard of the placebo response, which is the idea that, that health improves due to kind of a psychological effect of receiving treatment. The nocebo response is the flip of that. So it's kind of the opposite. It's the idea that a negative interaction with a healthcare provider, and the authors of this paper specifically call out invalidation, can lead to more of a negative response to treatment. And so the bigger idea here is that the context in which a treatment is administered can affect your response, whether it's positively in the case of a placebo or negatively in the case of a nocebo type response. And then there's a series of experiments that I find really fascinating, that really highlight the relationship between physical and social pain. These are kind of social psychology type experiments. And the English language really reflects these relationships. We talk about hurt feelings, we talk about the pain of a broken heart. And it's my understanding that not just English, but a lot of languages kind of have this linking in their linguistic structures as well. And there was a series of experiments about 20 years ago. Eisenberger performed fMRI brain scans on people while they were kind of undergoing this experiment, this task that mimicked social exclusion. And interestingly, what they found is that this social rejection task, or this process they went through, actually activated neural regions of the brain that overlap very strongly with areas that also light up when you're undergoing physical pain as well. And so they concluded that social exclusion, of which invalidation is a form, and that rejection, that they do actually hurt kind of in the brain. They show up in the brain in the same way. And so there is this kind of biology of exclusion. And they hypothesized that this makes sense kind of from an evolutionary perspective, because humans are built to be social beings. And so our brains sort of evolved, potentially they evolved in such a way to kind of alert us similarly when there's danger of physical pain, but also when there's danger of kind of these social bonds being broken or threatened. And they actually followed it up with additional experiments a few years later, where they measured, so they gave people a heat stimulus, which is a sort of mild form of pain, and they asked them to rate how unpleasant that was. Everyone got the same actual level, but people varied in terms of how unpleasant they rated that heat stimulus. And then they did the same kind of, exclusion mimic task, and they asked them to rate how distressed they felt about being excluded in this task. And they found that those two ratings, to the heat stimulus pain exercise and also to the social exclusion one, were very strongly related. And so they concluded there's this shared sensitivity to both. And interestingly, that exists also regardless of levels of anxiety, regardless of personality characteristics. When the researchers controlled for those factors, those relationships still existed. So I think we can kind of think about like what informs this sensitivity to both. And I'm not sure, but certainly genetics, past experience to either physical or social pain, and certainly trauma, and maybe other factors as well. But I think I think they're very interesting because they provide support for the idea that these invalidating experiences are significant, and they provide kind of a basis for why symptoms might be higher in the context of additional invalidation, because our human biology kind of just considers them to be important and linked in that way. But the good news is that it does go both ways. There's been a lot of research that greater social support, which is kind of this notion of feeling cared for, that you have assistance, and that you're part of the supportive social network, both tangible and intangible. But greater social support has been linked to less pain in the cancer setting, in the post-surgery setting, even labor and delivery. And it's also linked to less fatigue and less general symptoms. And so social support may be an important kind of factor that can attenuate activation of this shared system of physical and social pain. So the last kind of section I want to talk about what I see as some next steps and future directions for this work. First is more research. I'm a researcher, that's what I do. So I always think about more and additional research. I think we do need bigger, more diverse patient samples in terms of, as I mentioned, race, ethnicity, age, also geography, experience, lived experience, clinical experience, et cetera. I think that, this was everything I presented was exploring invalidation from healthcare providers. We know that it can also come from other sources, certainly friends, family, work, et cetera. And so that would be important to tease out as well. And then to also explore the impact of other interaction factors. Invalidation is kind of one dimension of these doctor-patient relationships, but certainly also you can consider trust, support, or uncertainty or other things that would be good to explore as well. And then another really significant hole in the scientific literature that I see is that of the physician perspective, which I think is needed to help try and resolve some of these issues. The scoping review that I mentioned earlier in the talk mentioned a few survey studies that were done among healthcare providers. And what they showed is that there really is a lot of uncertainty among doctors about how to treat patients with Lyme disease, what best to do. And so there's really high levels of uncertainty. But this review also found that there were no qualitative studies that had been done among providers in Lyme disease. So we don't really have a handle on what's going on and why this is happening from the physician perspective. This is a quote from Atul Gawande's book, Being Mortal, which I think is interesting. He writes, "You become a doctor for what you imagine to be the satisfaction of the work, and that turns out to be the satisfaction of competence. Your competence gives you a secure sense of identity. For a clinician, therefore, nothing is more threatening to who you think you are than a patient with a problem you can't solve." And so I bring this part up not to excuse, harmful behavior on the behalf of physicians, but I do think that we need to acknowledge that they're operating within a medical system, within a training paradigm, that is not always conducive to effectively caring for patients with conditions like chronic Lyme disease. And also that we need to, if we're going to tackle these issues, we need to understand the perspective of physicians as well. Another point in terms of next steps, there's been a really great movement, and particularly more recently, towards more patient involvement in research, not just as participants, but as active collaborators. And I think that's really important to help truly understand and raise up these issues. At the Lyme Center, we recently started a study that we've called Provider Interactions and Qualitative Experiences in Lyme Disease, or the PEAK study. And we're involving a formal patient advisory board who have weighed in on the study design, and they will continue to advise on analysis and relevance and translation of our findings. We're conducting semi-structured interviews. We're allowing patients to submit written pieces on positive and negative interactions with healthcare providers in Lyme disease. So I think this is important going forward, and particularly to involve patients in a more formalized way. And then third is prevention. As a public health person, I always think about prevention. And to me, this work, it's a little bit kind of strange to translate to prevention, but I think that to me, it means thinking about ways to improve clinical practice so we can kind of avoid the issue on the front end. And how our work can circle back and really impact patients. And so the results, we want to be able to take those and publish peer-reviewed papers, which we started. We want to continue to do that. We want to really inform Lyme Center clinical practice on the small scale, segue into future projects, including research projects and knowledge dissemination. And then also influence medical education. That's kind of a bigger goal, and something that I want to think about how best to do. So a few words on this. I'm not a physician, but to me, as kind of an outsider, I think what this looks like is recognition that illness and validation is common in Lyme disease. I think it's understanding that it's a specific additional type of harm that should be acknowledged and addressed as part of the patient experience with Lyme disease. And then I think that potentially the most important piece that we can think about is how to separate out, how to decouple genuine uncertainty on the part of physicians about what's going on with patients, how best to treat them, how best to care for them, from this instinct to invalidate patient complaints. I don't have the answer to that, and I think the question marks are at the bottom because I think there's probably additional things to think about, and I'm certainly leaning on our patient advisory board and thinking of this as an iterative process between them and physicians as well to think about how best to make this work relevant and impactful. So in terms of the big picture of how this work fits into research on Lyme disease in general, both at our center and elsewhere, certainly a lot of what we do at the Lyme Center is to look at when patients are infected with Borrelia and then they're treated, what causes people to go down these different pathways? Why do some return to health and others have these persistent symptoms? And that's incredibly important work that we're trying to do, and others certainly as well. But I think another question that we can ask is, among patients who do have persistent symptoms, what contributes to this variability? Why do some have more mild symptoms that either resolve or don't, and others really have a much more significant and impactful illness that develops after treatment? And I think, I guess what I've been sort of talking through tonight is that I do think illness and validation is one small factor of many, but I do see it as kind of an unnecessary overlay onto this process. And as we know, it's one that seems to be related to higher symptom reporting. And so because it's unnecessary, I think in theory, it's modifiable, right? And so I think it's modifiable by finding ways to support patients through the process, to find ways to try and limit these experiences on the front end, and to think about how best to limit it in general going forward. And so I'm kind of coming to the end, but I want to leave with a quote from Arthur Frank, who's a pretty famous sociologist who wrote about his own journey through illness and through health. I think it was cancer. And he writes that the voices that speak to us at particular moments in our lives, especially during transitions or crises, imprint themselves with a force that later voices never quite displace. And so I like this quote because I think that it highlights that the way we handle these interactions matters, particularly at these times of transitions or crises, medical crises. And I think that applies to medicine. It applies to research, to bring these experiences into how we understand Lyme disease, to bring it into our paradigm of chronic Lyme disease. And it matters in kind of that individual one-on-one interactions between patients and providers. And so I think the more we can bring these issues to the forefront, incorporate them into our work, I think it's only going to help us design better studies, hopefully improve patient care, and then hopefully also for patients, help them to think about their own healing trajectories, as was articulated so beautifully by Shireen and Gina, and to think about how these experiences may have been personally impactful. So with that, I will just say thank you, first and foremost, always to participants for their time and effort and for sharing their stories. I'm part of the Hopkins Lyme Research Center, so I thank Dr. Aucott for his leadership and support always of this work. Ting and Erica for helping with the study that I presented the results from. tonight, and then Isabella and Leah for their help with the PEAK study going forward that hopefully I can come talk to you about in less than 8 years from now. And then lastly, just thanks to the Lyme Care Resource Center, Shireen, Gina, Phil, and Eric for the invitation, and to everyone for your time and attention tonight. So with that, I will conclude. I think there's maybe a few minutes for questions. I think Nancy's going to help us through potentially.
Sure, I can help with the Q&A. Allison, that was a great presentation. You covered a
Thank
lot of ground, and it's wonderful that you're doing this work. Thank you so much.
Thank you.
I think one of the messages that you said was how important having greater social support and networks are in healing and in the journey to wellness. And I just have to say that the Lyme Care Resource Center is a fantastic resource for support, and having these kinds of programs and webinars and years of supporting the patient community has made a difference. And I think just intuitively, they all stepped in towards this need and knew that they individually benefited and have built a community. And your research is now validating and supporting what they're doing.
Yeah,
And it all
absolutely.
ties full circle, right?
Yeah, totally. And I, a lot of what I presented tonight is kind of, like a no-brainer in some ways. I think, there's some neat pearls of wisdom there, but I think a lot of it is, like you said, really intuitive. But I think what's important is that it hasn't really been in the literature before, and it hasn't been appreciated scientifically in Lyme disease. And I think it's interesting to kind of think about how those pieces can come together, and hopefully lead to more recognition and more research as well.
And I think to your point too, also to bring it into medical education, you're doing the validating research that enables it to move forward into being accepted in medicine as an important piece that hasn't been taught, hasn't been known,
Yeah.
hasn't been understood. And the other thing is the sex and gender-based differences, I think, is an increasing area where there is more research and more attention, and this ties right into that as well. So in terms of how you get into the medical education piece, that might be one avenue. I don't know what your thoughts are on that.
Yeah, I mean, definitely as I presented this and we came to the realization really early on that you kind of can't study these issues without addressing gender, without thinking about sex and gender and how they interact with them. So I think that is an interesting avenue to look at. And there's certainly a lot of momentum around sex-based differences right now, and the impact of gender. And so I think that would be a good way of kind of thinking about integration with medical education for sure.
So we have a bunch of comments and some questions. Lorraine Johnson from My Lyme Data mentioned that women reported more tick-borne co-infections, worse symptoms, longer diagnostic delays, more misdiagnoses, and worse functional impairment than men in their study. So that's another validating study in this area. One question.
Yeah, and I'll say also, I mentioned kind of patient involvement in research, but I think also kind of these patient organized initiatives are really important too. Like I know Dr. Johnson's study as well, the My Lyme data and all of that too. I think that's another key piece to learning from patients and bringing those issues to the forefront so that we know what's relevant and what's important to study too. So yeah, that's great.
One question is how long COVID has changed the landscape for illness and validation.
Yeah, it's been very interesting to have been in this field for a long time and to have kind of COVID hit, and I think it has changed the landscape, certainly in terms of some increasing awareness and increasing funding, I think, for this type of research. In terms of invalidation, I was just thinking about this the other day. A lot of what I presented, the experiences that patients were reporting all happened pre-COVID. So that would be a really fascinating study to do, to kind of compare patients who had gone through the bulk of their experiences and their interactions with healthcare providers pre-COVID and post-COVID, and see if there is a difference. My guess is it's not huge, but there might be something there, and it might be interesting to do a qualitative study to look at that, because I don't really know the answer. I know on the large scale, I do think, if there's any silver lining to COVID, which is not very big, but I do think it has brought some degree of awareness of long Lyme as well, and how all these things are part of a bigger picture, like I showed with that Venn diagram as well. But in terms of invalidation, yeah, that would be a really fascinating study to do.
The other question is, well, has long COVID helped make long Lyme less of a contested illness? And the other piece of that is what research at the center is chipping away at validating the illness, perhaps not to the level of specific biomarkers, but just to validate that this is a real illness, that it's not psychosomatic, such as the brain imaging studies, such as the early diagnosed and treated study. There's a number of studies that the center has done to help validate this and to make it not a contested illness.
Yeah. I mean, as I said, I think I research is my thing. I think that's always going to be kind of the way forward. And I think that our center and others too, certainly, have really kind of have shown that through research. You mentioned the fMRI studies that we've published, and there are more coming in that realm fairly soon. I know Dr. Aucott presented on that earlier this year too. But I think, as I presented it, the definition of contested illness is kind of this discord between patients with a medically, quote, invisible condition and then kind of modern biomedicine. And I think that we're starting to put those pieces together where it's no longer a question within modern biomedicine, that we can find these biomarkers, that we can find, they might be subtle, and they may just not be as blatantly obvious, but they are there. And I think it's, as Dr. Aucott says, it's kind of time to put to rest this idea that it's not real. I think we're starting to really come at it multiple ways. And again, I think long COVID has certainly helped with that. And yeah, being in the field for some time, it's been interesting to see that evolution, and I hope it continues. I hope that there's still funding, there's still these linkages being made. I'm learning more and more about long COVID every day, and more of these contested illnesses to try and make those connections and bridge those gaps. So I think I do sense that there's a different type of momentum and a different kind of sense of purpose that's shared across multiple conditions, rather than feeling like we're in this Lyme silo doing this work, and there's more bridges being built now, I think.
We have a few questions about whether your talk and your slides and links to the studies are going to be available, or how people can access this information if they want to see it again.
Yeah, I think I'm not sure within the Lyme Care Resource Center how that is done. I'm happy to, certainly our publication that just came out, I think it's open access. I can send a link to that to read that. The information on the slides, yeah, I'm happy to share however Gina and Shireen would like to do that. Yeah.
And there's a number of comments on the Q&A thread that are very personal and individual. And I just want those who have made those comments to know that these will get sent to the practitioners at the Lyme Center so that they're aware of your issues. Alison cannot address these in this forum, but we want your voice is to be heard, and I just want you to know that we're paying attention to it, and we will make sure these comments get passed along so that we can be educated. Everyone involved at the center can hear what you're saying. And we appreciate the struggles that many of you have had.
Yeah.
Oh, and I've just been informed there will be a recording of this on the Lyme Care Resource Center in the future. So circle back onto their website.
Well, I think, I mean, Nancy, I think we're getting pretty close to time, and I know Phil has some concluding remarks, so maybe I'll pass to Phil if that's all right, given that it's almost 8:30 here.
Yes, thank you so much, Alison, for your presentation. It was full of great information and certainly validates what I've experienced personally over the years. And Nancy, thank you also for joining us tonight. Yes, on our website, this will be posted within the next 30 days, lymecenter.org. So stay tuned for upcoming events. And also, there are over a dozen recorded presentations that have been done over the years of many, many topics on the on our website. There's also a great wellness tips, 6-page fully colored wellness tips of lifestyle living of those people with chronic Lyme disease. So there's some tips that have come in from a lot of different sources that were on this brochure. You can download the brochure, or you can contact Gina and she'll mail you a copy of the brochure. It's got some great stuff in there. Every May, John Alcott gives us an update. So if you go online on our website, there are pre-recordings of studies and what he's found over the years. I want to thank you all for coming tonight. I want to thank you all for the donations that you've given to us this past year. The donations between now and the end of the year will be doubled. So if you donate $10, it's going to be $20 that's going to the Lyme Care Resource Center. So we want to thank you for the donations. We want to wish everybody a happy Thanksgiving and upcoming holidays through the end of the year. Stay tuned. We'll have more stuff for you in 2025. Good night and God bless.